Hi everybody, welcome back to UWorld's Next Gen NCLEX review session. My name is Jackie and I'm a nurse here at UWorld. I'm so glad to be back with you guys today on this Tuesday. We have a big topic we're covering today. We're going to be talking about acid-base imbalances and ABGs, or arterial blood gases. So we have a lot of good content that we're going to cover, some questions at the end, so make sure you stick around for that. As always, we hope you'll be following us on your favorite social media channel at UWorld Nursing. This session will be available on demand on Facebook and YouTube when we're done. And as we always say, drop your comments in the chat. Let us know, what you want to hear, what questions you have about the content. We have our content experts moderating, so we're here to help you guys, support you along the way. And with that being said, we're going to kind of jump into our content. We have a lot to cover today. So if you're just joining us, again, we're covering acid-base imbalances. So we're going to cover metabolic and respiratory alkalosis and acidosis, and then talk about some memory tricks to kind of figure out ABGs and what we're interpreting when we see them. All right, so kind of starting at the beginning with acid-base imbalances. So these are going to be a complication of a condition. They're not like a standalone diagnosis, so you can't like catch an ABG or transfer an ABG. It's going to be something that's happening due to a larger problem that's going on. So these imbalances, they're typically going to be focused on dysfunction of like one of two areas. So when we have metabolic imbalances, we're going to have kidney problems. And when we have respiratory imbalances, we're going to have lung or breathing problems. So again, like we've said many times before, we need to understand like our normal ranges and what normal looks like to know, as lab values change, what we're seeing and what we're experiencing. So we're going to focus on 3 lab values. And again, these will be provided to you on the NCLEX. But first up is pH. So this is going to tell us if our blood is acidic, normal, or alkalinic, or base. And so a normal pH is going to be 7.35 to 7.45. Low numbers mean acidosis. So that means we are very acidic when we are on the low end of that scale. And then high numbers are going to mean alkalosis, meaning we're going to be more base when we're at that end of the scale. Okay, so next we have CO2. And again, we'll have images that have all of these numbers in it. We're just painting the picture right now, so don't be too worried about these numbers. So next up is CO2. And we learned a lot about CO2 on some of these lives, especially our COPD live. But we know that high levels of CO2 are going to make us acidic. So we're going to have a low pH. A normal CO2 range is going to be 35 to 45. So you can kind of just like remember that by dropping the 7 on the pH scale. So normal CO2 is going to be 35 to 45. And then last up we have bicarb. So again, as we're looking at all of this, we're focusing on our pH, our CO2, and then last up is our bicarb. Okay, so bicarb is HCO3. A normal bicarb range is going to be around 22 to 26. High levels of bicarb are going to make us alkaline or have alkalosis or basic. So again, just general principles of all of this. Acidosis is going to be too much acid or a loss of base, and then alkalosis is going to be from too much base or a loss of acid. So we're going to pull up a scale for acidosis, and please know I made these images and they are not fancy, but I hope they paint a good picture for you guys. So again, we'll bring up an acidosis scale, and this is just to kind of get that big principle of acidosis kind of visualized in your brain. So again, we know it can either be from too much acid tipping the scale towards the acidic side, or a loss of base causing the acid side again to tip down. So hope that's helpful. But again, don't judge my work on that, but again, hope it helps. Okay, so we're going to warm up the chat. I want to know from you guys, what do we know about metabolic acidosis? So what are some causes of metabolic acidosis? So what's going to make us acidic in terms of thinking about our kidneys? So let's see what we have. Put your comments in the chat, and I'm looking too to see some of you guys are testing soon, so let us know too when you guys are testing. We'd love to wish you good luck, and let us know when you pass so we can congratulate you. All right, okay, good work you guys. I'm seeing So, and thank you for the compliment on my image. Okay, so I'm seeing some diarrhea, vomiting. We're going to talk about both of those, a little bit different for acidosis versus alkalosis. DKA, very good. Okay, good job, you guys. Good to see some answers coming in. Again, don't be afraid to use the chat. No wrong answers here. We'll walk through all of it together. Okay, so causes of metabolic acidosis. That's what we're going to kind of start with that today. So again, we know metabolic means kidneys. The kidneys are going to be impacted. Acidosis means too much acid or a loss of bicarb. So some reasons this can happen can be either too much production. So think of like an increase in lactic acid circulation from poor perfusion or even carbon monoxide poisoning. And then when we hear lactic acid, we think about sepsis as well. It can also be from the release of ketones. So think about DKA, which you guys had in there, or even taking too much aspirin, we can get salicylic acid poisoning, or even impaired excretion. So again, this is going to happen with like kidney disease. So remember, our kidneys decide what goes out through the urine and then what gets like sent back into the blood. So if they, if they're not working or they get backed up, we're going to have a buildup of those waste and electrolytes in our blood, including those acidic elements. So lastly, you guys had this in here, diarrhea. You definitely have that right. So we can worry about losing our base or our bicarb when we're thinking about like excretion problems like diarrhea. But there's going to be a big differentiation of like our stomach as kind of like a decider of acidosis versus alkalosis. So we'll jump into alkalosis next, but vomiting and diarrhea usually they go together as like a group of symptoms for something, but diarrhea is going to cause acidosis and vomiting or suction is going to cause alkalosis. So I kind of gave you an answer for our next question, but we're going to pull up an alkalosis scale for you guys now too. So same principles of acidosis. We can have alkalosis from either too much base or a loss of acid. So just again, to help paint a picture for you guys, but I want to know in the chat again, let us know about what do you guys know about metabolic alkalosis? So what are some examples of causes of metabolic alkalosis? You guys definitely had vomiting that was a good one. Good job, everybody. Again, put some of your thoughts in here and we'll, and good luck to our viewer testing on the 15th. That's exciting. Good luck, good luck. Good work, NG tube section. That is very true. Good job, you guys. Okay, awesome. So we'll kind of jump into metabolic alkalosis. So again, same principles of acidosis are going to apply, but we're going to reverse it. So metabolic, again, means our kidneys are impacted. Alkalosis is going to mean either too much bicarb or a loss of acid. So some reasons for too much bicarb can be just like as simple as excessive ingestion of bicarb, like antacids. So they're pretty much just little tablets of bicarb. And if we take too much in, this can kind of alter the pH of our blood. Or large amounts of acid loss. So again, remembering that image of the scale and anything that's going to tip the scale towards that base side. So this can be anything, again, loss of acid, anything from the stomach up. So think about our stomach is full of acid, and if we have excessive vomiting or suction from like an NG tube, that's going to be pulling that acid out of our stomach, and that's going to make us more base. And then in the same vein, certain medications like diuretics and thiazides, they're going to cause excretion of hydrogen in our urine, and we know that hydrogen is a big driver for pH as well. So if we're losing hydrogen, we're losing acid. This is going to cause our pH to be higher. All right, so we're going to bring up for you guys now to a table, and this is a great thing you can take a snapshot of. It's going to kind of summarize all metabolic acidosis, alkalosis, respiratory acidosis, alkalosis. So we'll show it a few more times during the session today, but again, take a screenshot. This can help get everything straight in your brain, but hopefully this will help kind of with the rest of our discussion today. Okay, so clinical features. What is metabolic acidosis going to look like? again, remember DKA, that was one of our causes of metabolic acidosis. So clients may have like Kussmaul respirations. They're going to have signs of hyperkalemia. We might even see those tall peak T waves on our ECG. And we know they're going to have diarrhea as well. So we're going to see diarrhea. We know it's a cause. We know we'll see it. Okay, so then on the flip side, we have metabolic alkalosis. So there's not a ton to say about this one. Same lines. We're going to see it like as diarrhea. We're going to see vomiting. We know that's a cause of it. But in general, our client's just going to feel unwell. And again, we'll reiterate this as we go today, but all of these imbalances, they're secondary to a condition. So they're not causing all of these symptoms. They're going to be caused by symptoms of another condition, if that helps. Okay, so we've covered clinical features, metabolic acidosis and metabolic alkalosis. Let's talk about compensation, because whenever we have these imbalances, if our kidneys are having trouble, our lungs are going to step in and help us, which seems a little disjointed, but it's all about the acids and base, and the end product is that pH in our blood. Okay, so talking about compensation for metabolic acidosis. So again, remember we have a low pH and we have low bicarb. So in response, our lungs are going to kick in, they're going to help out the kidneys. So they're going to increase their rate. So we're going to have an increased respiratory rate so we can blow off CO2, which is acidic. So again, if we have too much acid due to metabolic situations happening, we're going to use our lungs to eliminate another acidic element, which is CO2. So we have high acid from a metabolic situation. We're going to use our lungs to get rid of another acidic element, which is CO2. So when we blow off that CO2, our pH is going to rise, because remember, if we're acidic, we have a low pH, and the bicarb over time is going to compensate and rise as well. So we'll flip the script, talk about metabolic alkalosis. So this is going to be the opposite. We have a high pH, so that means we have low acid circulating. So in response, lungs are going to slow down. They're going to help out the kidneys. We're going to see a decreased respiratory rate so that we're holding on to that CO2. Again, that CO2 is the acidic element. We're going to hold on to that CO2 so it can help lower our pH. And then over time, that bicarb is going to lower as well. Okay. So we're going to do a knowledge check before we move on to nursing interventions, what a nurse will do in this situation. Okay, so if we have metabolic acidosis, will our breathing increase or decrease? Metabolic acidosis, will our breathing increase or decrease? Drop your answers in the chat. Let us know what you think. And thanks for everybody who's following us on TikTok and sharing this session. We hope you'll share it to more nursing students. The more the merrier, we always say. Okay, so if we have metabolic acidosis, to compensate, is our breathing going to go up or down? Acidosis, we know we have too much acid, so how are we going to get rid of that acid? Good work, everybody. I'm seeing some increases. Good work. So yes, so our breathing is going to go up so that we are blowing out that CO2. Again, if we have acidosis, we need to get rid of acid. CO2 is our kind of compensation, our compensatory counterpart. So we're going to blow out the CO2 to have less acid circulating, and that's going to raise our pH. So good job, you guys. Okay. Nursing interventions. So again, when we're talking about metabolic acidosis or metabolic alkalosis, again, it's never the primary diagnosis. It's going to be a symptom or a cause, a complication of something else that's going on. So first thing we need to do and need to identify is we need to treat that underlying cause. So there's going to be some essential practices that we're going to do as a nurse. So in general, we're going to monitor our ABGs. So again, an ABG is really the specimen of blood that we're taking, our arterial blood gas. That's going to give us all of this information about our pH, our CO2, and our bicarb. So again, that's really what's going to drive our interventions. Let us know what's happening with our client. So in general, though, for metabolic acidosis, we need to monitor those lab values, especially lactic acid. We know lactic acid can be contributing to this. So again, think about sepsis. How do we need to treat this infection that's happening? We're going to need to replace fluids and electrolytes as needed, and we're going to need to give certain medications. So again, acidosis we talked about is diarrhea. So we might need to give this client some antidiarrheals. And then also for metabolic alkalosis, again, same principles. We have to treat that underlying condition, understand what's causing it. We're going to have to give medications to treat vomiting, so some antiemetics, and then we might have to stop the use of diuretics or those medications that are sending that hydrogen or excreting that hydrogen. We want to send it back into the bloodstream because, again, if we're alkalosis, we have too much base, so we need to counteract that with an acid. Hydrogen is that acid, so we want it to be reabsorbed into our bloodstream. And then again, if suctioning is the problem, maybe we need to change the suctioning, discontinue suctioning, reevaluate what's going on there. Okay, so we have another image we're going to pull up for you guys. This is a flow chart, and I encourage you guys, take a snapshot of this. This is really going to give you the full picture of how you can interpret lab values for these clients. So again, we'll pull up a flow chart for you. It's going to walk you through like acidosis, alkalosis, metabolic, respiratory, uncompensated, compensated. So it's going to take you start to finish. It's going to be your roadmap. Just use it as you go through questions as you're getting used to these things. But I just want to give you guys a quick summary, and you can kind of follow along on that flow chart. So metabolic acidosis, it's going to mean a low pH. Again, acidosis, low pH. When we have too much acid, our pH is low. We're also going to have low bicarbonate as well. So our kidneys are first going to try and compensate, and then they're going to call in the lungs for backup. So our lungs are going to breathe faster to blow off that CO2, which is also an acid. So we're going to try and, in that scale image, we're going to try and take an acid off the scale to lean us a little bit more towards the base side. When that pH returns to normal, we're going to be fully compensated, but we'll have a low CO2 from blowing it off from, that hyperventilating. And so we can have a secondary respiratory alkalosis. So we'll get to all of this. And then metabolic alkalosis, again, it means we have a high pH. This happens from low hydrogen and high bicarb. So our kidneys are first going to try and compensate, then they're going to call in the lungs for backup. The lungs are going to breathe slower to retain that CO2, retain that acid. And then when the pH returns to normal, we're going to be fully compensated, but we're going to have a high CO2 from retaining it. So we can call this, again, secondary respiratory acidosis. So this overcompensation to compensate can cause another kind of issue. So again, take a screenshot of that flow chart. We hope it's helpful for you guys. We're going to pull up the table again because we're going to jump now to respiratory. So we're going to talk respiratory acidosis, respiratory alkalosis. Okay, so patho of respiratory acidosis versus respiratory alkalosis. So again, we talked about the respiratory drive on our COPD session, but just a quick refresher. We breathe in oxygen. Oxygen makes it all the way through our upper and lower respiratory system. Gas exchange happens in our alveoli. Our blood is going to offload that CO2 and it's going to pick up that oxygen, and all this happens at that alveoli. So the CO2 is really where this imbalance is going to happen. So in respiratory acidosis, when we are hypoventilating, again, we've talked about this already. When we're hypoventilating or breathing slowly, we're going to have a buildup of CO2 in the blood, making us more acidic, making us have a low pH. On the other hand, respiratory alkalosis, is where we're hyperventilating or breathing too fast. We're going to blow off that CO2 too quickly, and it's going to raise our pH due to a lack of acid. And this is really the core of what's going on with respiratory alkalosis. So again, quick refresher, hypoventilating is going to be respiratory acidosis. We're retaining that acid, that CO2. Hyperventilating, think of your breath out as that CO2. If we're breathing out all that acid, our blood is going to be too basic, or we'll have respiratory alkalosis. Okay, so causes of respiratory acidosis. I know you guys can probably see it on your screen, but let us know some examples. We're going to use that chat again. Let us know some causes of respiratory acidosis. Maybe something that was new to you, you didn't know, or anything like that. We want to see what you guys have. But good job, everybody. You guys are doing awesome. Good work, good work. All right. Awesome answers coming in. So yes, we will walk through all of these. But again, if we're talking about respiratory acidosis, we're thinking about hypoventilation. I just am seeing some come in. COPD, very good. Okay, so if we're going to talk, when we talk about respiratory acidosis, we're talking about hypoventilation. Again, retaining that CO2. That CO2 is the acid. So we're going to start with some like acute causes. So first, our client can have airway obstruction. So think along the lines of like choking or aspiration. We can also have chemical like respiratory depression, anything along the lines of like opioid overdose or alcohol intoxication. And then last, we can have like respiratory muscle weakness. So think about things like Guillain-Barré syndrome, spinal cord injury even. So the part of the brain that controls our breathing is in our brainstem. So some of those cervical spinal cord injuries that can affect our breathing, that can decrease our breathing. And then on the chronic side, we can see things like obstructive pulmonary disease, like COPD. So we've talked about how clients with COPD, their respiratory drive is going to be triggered by oxygen instead of CO2. So their body becomes so accustomed to these rising levels of CO2 that it's going to blunt their respiratory system's response. Okay, so we covered kind of some of those causes for respiratory acidosis. What are some causes of respiratory alkalosis? So again, alkalosis where we have too much base, not enough acid. What is the respiratory drive that's going to cause this? So put that in the put that in the chat what you guys think. Good answers on here for like morphine too. Good work, you guys. Awesome. All right, I'm starting to see some stuff come in again. We're looking for some causes of respiratory alkalosis. Good work, you guys. Okay, so we're moving on to some causes of respiratory alkalosis. So again, respiratory alkalosis, it's going to be hyperventilating, breathing too fast. So let's talk about things that can cause hyperventilating, just at the basics. Panic attack. We can have pulmonary conditions like pneumonia, asthma attack, pulmonary embolism. All these things are going to cause impaired gas exchange, either from obstruction in the airway or in the lungs. So other causes can be things like fever, high altitude, or improper ventilator settings. Okay, so what are our clients going to look like? Our clients with respiratory imbalances. So our clients with respiratory acidosis, they are going to have decreased respirations. Again, these clients are going to show like the neurological manifestations of high CO2 and low oxygen, or so think about like hypoxia. They're not going to be getting enough oxygen to the brain. So they're not breathing fast enough, that CO2 is building up. When we think about low respiratory rate, what is our brain going to be doing? It's going to be a little bit delayed. So we're going to have some confusion, some lethargy, drowsiness, headache, things like that. And then as it progresses, we're going to see some late signs like seizure and coma. Okay, so you guys are doing good. Good work, everyone. We're going to move on now to what clinical features of respiratory alkalosis. So again, respiratory alkalosis, we're going to have low CO2 and a fast respiratory rate. So think about, how this will look in our brain. We're going to be lightheaded, dizzy, confused. We might have some tachycardia. Again, think about this is all associated with like a panic attack where we're hyperventilating. And then due to other processes happening in the background, we're also going to have some signs of like hypocalcemia. So we might have some things like tetany or numbness and tingling. And then same as respiratory acidosis, late findings of respiratory alkalosis are going to be seizure and coma. We need to know how to identify these findings and treat the client before it progresses to this. Okay, so we've kind of gone through causes, what this is going to look like. Let's talk about that compensation element. So we talked about how with metabolic imbalances, the respiratory system, the lungs kind of jump in to help compensate. Same idea with compensation for respiratory imbalances. Our kidneys are going to jump in and help with some of this compensation. Okay, so just So in respiratory acidosis, we know we're too acidic from a buildup of CO2. Our kidneys are going to jump in by secreting hydrogen in the urine. So we're going to be losing another acidic element in our blood through the urine. So again, we know hydrogen is an acid. It's going to lower our pH. Remember, low pHs mean acidic. And so by excreting that urine, we're going to take what was respiratory acidosis. That acidosis is going to move more towards a normal pH. And then also our kidneys are going to reabsorb or send back that bicarb to the bloodstream. So bicarb is a base that's going to help raise our pH as well. So again, think about that scale. If we have too much acid and bicarb coming out, we need to offload an acid and add a base back in to kind of get back to that normal range. Okay, so now with respiratory alkalosis, we know we have low levels of CO2, so we need to increase the amount of acid in our system to help lower our pH. So our kidneys are going to reabsorb hydrogen to send acidic hydrogen back into the blood, and they're going to reduce the amount of bicarb that's being produced. So again, this is going to bring our pH back down to normal. Okay, before we get into nursing interventions, then we have our questions. So stay tuned. We have 3 questions we're going to go over with ABGs and interpreting it. I want to do another quick knowledge check, then we'll talk nursing interventions. Okay, so we talked about hydrogen. Will hydrogen concentration go up or down in respiratory alkalosis? Is it going to go up or down in respiratory alkalosis? So as you guys are putting your answers in the chat, if we have respiratory alkalosis, we know we are too on the base side. We know hydrogen is an acid, so how is hydrogen going to jump in and help in this situation if we have if we are too base? Awesome. I'm seeing a bunch go in. Good work, you guys. Yes, increase. Good answers, everybody. Good work, you guys. Awesome. So again, our hydrogen concentration is going to go up to help lower our pH and counteract our respiratory acid alkalosis. So good job, you guys. Okay, so nursing interventions for respiratory. Again, remember, this is never going to be a primary diagnosis, but a symptom of another condition. So we need to treat the underlying cause, and then again, same principles. We have some basic interventions that we're going to do. We're going to monitor our ABGs. We're going to give fluids. We're going to monitor electrolytes and give as needed. But for respiratory acidosis, we need to work on improving our airway and our breathing. So we need to raise the head of the bed. We need to suction the client if secretions are a problem. We may need to give supplemental oxygen and give medications that are going to treat the condition. So again, if we're hypoventilating due to opioid intoxication, maybe we need to give more Narcan. We may need to intubate the client. Again, send the breathing to a third party, which is the ventilator. And then for respiratory alkalosis, we need to also work on kind of improving our airway, and breathing might look a little bit different. So we may need supplemental oxygen and medications, but these might be like benzodiazepines to help calm our client down, slow that breathing down. And we're going to want to encourage that slow, deep breathing. So hopefully that was helpful. Good work, you guys. We're going to bring our flow chart back up for you guys. I'm going to do a quick summary again of what's happening with our respiratory acidosis, respiratory alkalosis. And then we'll move on to our questions. So hope this was helpful, and we'll talk about a little trick as well. Okay, so respiratory acidosis, again, acidosis means low pH. This happens from hyperventilating and too much CO2, so we're not blowing off that CO2 enough. Our kidneys are going to compensate, but this is done very slowly. So our kidneys are going to increase elimination of hydrogen to help raise that pH in our blood. They're also going to retain bicarb to also help raise that pH. So again, think about that scale. But this happens slowly, so again, we might need other support like airway support, breathing support, anything like that. And then in respiratory alkalosis, again, alkalosis means high pH. This happens from hyperventilating, from low CO2. That CO2 is an acid. Our kidneys are going to compensate. They're going to do this slowly though. Our kidneys are going to hold on to that hydrogen in the urine, which is an acid. It's going to help lower our pH. They're also going to lower bicarb production. So again, these two things are going to lower our pH, bring it closer to the middle. And then these are going to happen slowly. So again, if our client is awake, we need to encourage them to breathe slower. If they're on a ventilator, we may need to decrease the ventilator settings. Okay, so that really covers our big content. We have one more image we're going to pull up and then we'll get to our questions, but this was a trick I learned in nursing school. I hope it can be helpful for you guys. But as you get these questions either in nursing school or on your NCLEX, this mnemonic Rome really helps. And so we'll walk through kind of the basics of how you approach it. So for Rome, the R and the O stand for respiratory opposite. So your pH and CO2 are going to be going in different directions. So if you have a pH that's high, a CO2 that's low, that's going to indicate a respiratory situation. If you have, and then the M and the E means the metabolic equal. So if your pH and your bicarb are going in equal directions, that means you have a respiratory process going on. And then we take it a step further. Uncompensated means you're going to have an abnormal pH. Again, the supportive system hasn't engaged yet, so our pH is still going to be abnormal. And then you're going to have a abnormal pH and then like a normal, whatever that compensatory counterpart is going to be, because again, they haven't done anything. Then you can have compensated. So again, you can have a normal pH, but you're going to have an abnormal CO2 and HCO and bicarb. So again, that compensatory mechanism has activated, so you're going to see levels that are abnormal around across the board. Okay. So again, take a screenshot of that. Just remember the basics though. Respiratory opposite, metabolic equal. And so we'll take this principle and kind of apply it to the questions that we pull up. Okay, so our first question, we have some lab values there. We have a we'll pull up the question for you. We have lab values, and then we have a pH. I'll just walk through the lab values. You guys can see what the options are, and then drop your answers in the chat. What do you guys think the right answer is? All right, so our pH, we have 7.28, so we know we have a low pH. We have, I'm just going to jump to the bicarb, or to the CO2. Our CO2 is 55, so we have a high CO2. So again, thinking back to that Rome example, we know that the issue here is probably respiratory. And then we have a bicarb that's normal. So we know that we have an uncompensated situation happening here. So you guys tell me, drop your answers in the chat. What do you think the right answer is? Are we having respiratory, acidosis, alkalosis, metabolic, acidosis, alkalosis? Let's see what we got. Good job, you guys. Awesome answers coming in. Good job. Good work, you guys. I know this is hard. Did you guys learn Rome in nursing school, or is that something new to you guys? It was helpful for me. Just, stick to your arrows, stick to what you know. Good job, you guys. Okay. So you guys definitely have it. So again, our answer is going to be respiratory acidosis. So again, going back to the principles of the flow chart even too, and Rome, our respiratory, our pH and our CO2 are going in opposite directions. So we know that we're going to have a respiratory situation. Our pH is low. That means we have, we're too acidic, and you can tell that CO2, we know that's an acid, and it's off the charts high, so that's going to mean we're more acidic. So again, respiratory opposite, pH is low, CO2 is high, but when we have a high acid, that means our pH is going to be dropping. So good work, you guys. Okay, we're going to pull up question 2. I'll give you guys a chance to read it, and then I will walk through the lab values we need to know. So good work, you guys. Okay, so we have a pH of 7.48. Okay, so we know we have a high pH. We have a CO2 that is 30, and then we have a bicarb of 24. So again, we know we have a low CO2, so we're low on the acid side. Our bicarb is normal, so we know that we are uncompensated, and we also know we're uncompensated because our pH is outside of the normal range. So we have a high pH, we have a low CO2, so we know we have arrows going in opposite directions. So what do you guys think the answer is? Good job, you guys. Awesome, awesome. Good work, good work. Again, high pH. What does high pH mean? I'm seeing a lot of good answers come in. But remember, high pH doesn't mean acidic, it means the opposite. So let's see what you guys think. Good work. A lot of great answers coming in. Good work, you guys. I know this is hard, but again, I feel like if you understand the disease process and what's really happening, it helps a lot to, apply that knowledge to these questions. Okay, so we will walk through this one. Again, we are seeing here respiratory alkalosis. So again, our pH is high, or our pH is outside that normal range on the high side. So we know high pHs mean we are too base, we have alkalosis. We know that CO2, it's going in an opposite direction. So our pH is pointing up, our CO2 is pointing down. So that means that we have respiratory alkalosis. So if we have low circulating CO2, we have low circulating acid, meaning that we're going to veer more towards the base side of our pH scale. So good job, you guys. I'm seeing a lot of good answers coming in. Awesome, awesome. I hope this is helpful. Okay, last question. This one's a doozy, so just hang in there. Okay, so again, I'll let you guys read the question, and then I will read the lab values for you. So what we're seeing here, we have a pH of 7.37. This is our first normal pH. So what is that going to mean, that we have a normal pH? We have a bicarb that's low. I'm sorry, not a bicarb. We have a CO2 that's low, 33. We have a bicarb that is also low as well. Okay, so what are we going to see? What are we going to see? Are we seeing compensated, uncompensated, acidosis, alkalosis? What are our arrows doing? Awesome, awesome. All right, you guys. Good work, good work. I'll give you guys a little bit more time. And again, this will be available on demand. You guys can always go back and look at it, refresh, do these practice questions again. And if you guys like these kind of questions, we can even incorporate this into one of our question drills too. And obviously we can take our time, walk through them, and get a little bit more practice in. Okay. So starting with this one, what we're seeing is we have a pH of 7.37. Okay, so we know we're compensated because we're in the middle here. And then what we're seeing too with our CO2, we're seeing two values that are out of that normal range. So again, what our lab value, if you kind of think of your pH as like 7.4, your middle point, 7.37 was trending towards acidosis. So that's how we're going to kind of start with this. Even though it's in that normal range, it's going to be more on the acidic side. So we're going to say we have acidosis. Then we're going to look at our CO2. Our CO2 is low. So if we have a low pH and a low CO2, we know it's not respiratory. So again, let's move on to our bicarb. So our bicarb is low. It's 20. So thinking our pH was on the low side, our bicarb is on the low side. We have two matching arrows. Again, that ME and rho, metabolic equal. Our pH and our bicarb are going down in the same direction. But we know that our pH is in that normal range, so we've been compensated. So that's how we know this is going to be compensated metabolic acidosis. So we had metabolic acidosis, but our lungs kicked in and it's compensated. So our pH is back in that normal range. So that uncompensated versus compensated all relates to what our pH is saying. And then we just have to see which side of normal are we on. So I hope that was helpful, you guys. You can never do too much practice with these ABGs. The more you do it, the more you'll get familiar with it. But you guys did awesome on that. So well done. We have a schedule for this week that we'll pull up for you guys. Tomorrow we're going to be doing a question drill on fundamental questions. So if you guys are just getting back into nursing school, hopefully this can be helpful for you guys. And then Thursday we'll be covering some prioritization questions as well. But as always, we encourage you, and I should say, those are at 3 p.m. Central Time on TikTok and Instagram. So we hope y'all will join us there. And then as always, we encourage you guys to check out our website at nursing.uworld.com. We have tons of great resources to help you guys prepare for your NCLEX, get back into nursing school, everything you need to know, including our 7-day free trial, which is going to give you a great taste of what UWorld's all about. From questions, lecture videos, NGN's case studies, NGN standalone items, and our awesome explanations. So we hope it can be helpful. We hope you'll check us out and always follow us for more information on our live sessions coming up. And we look forward to seeing you guys tomorrow. Thanks again. Bye.